Hello everybody and welcome to our 7th Ask the Expert live Q&A, and this session is going to be about ERCP and PSC. So I'm Maxine Tapp and I'm the Programme Development Officer for PSC Support and a liver transplant patient, and I'm here today with Martine Walmsley, who is also a PSC patient as well as full-time volunteer and Chair of Trustees for PSC Support. And we're really pleased to be joined this evening by Dr Joshi, Consultant Hepatologist at King's College Hospital in London. So Dr Joshi is the clinical lead for HPP medicine, an advanced biliary endoscopist, and specialises in paediatric ERCP. He's a member of the BSG Liver Committee and is a co-author of the book Hepatology at a Glance. His current research interests include the management pre- and post-liver transplantation of biliary disease, including the role of endoscopy. So if you're watching this live, please ask your questions by commenting on this video, and we'll try and get through as many as we can in the next 30 minutes. So welcome, Dr. Joshi. Thank you for giving up your time for us this evening. It's great to have you.
Thank you. Thank you for having me.
And so we'll hand over to you. You're going to do a short introduction on ERCP, so we'll hand over to you for that.
Yes. So thank you, Maxine. Thank you, Martine, for this opportunity to talk about a subject I'm really passionate about. So we are going to talk about ERCP, and we're going to sort of tailor it towards PSC. So I think I've got 7 or 8 slides, and I'll just go through some of the basics. Some of the people on this call will have had an ERCP. They might be going to have an ERCP, and maybe this will help. So I think, you know, it's always best to start with the anatomy, the basics. So with the liver, you have 2 lobes. You have the left lobe, you have the right lobe, but embedded within them are your bile ducts. And you can see here is the main bile duct, which comes up and then it branches off to the right and off to the left. And there are different ducts which feed different segments, which if we want to be very nuanced, then we can, when we're doing an ERCP, aim for them. So I always feel, actually, let me see if I can find the slideshow. There we go. I always feel it looks a bit like this. This is, I think, apple and elderflower. It's available from a sort of a high street supermarket, but this often reminds me of the bile duct. So you have your main bile duct, which runs up and down. You have your gallbladder, which I think are the leaves here. And within the liver, you have your bile ducts, which then often go off into smaller branches, even smaller branches, and then to a microscopic level. So if you ever want to think of what a bile duct looks like, the biliary tree, then think to your sort of elderflower. This is my artistic impression. This is my drawing. I did do GCSE art a very long time ago, but what you can see, it's all very nearby. So it's all relevant. So from the blood supply to the liver, which is the portal vein, which feeds into your pancreas, which sits very nearby, your bile ducts, your small bowel and your stomach as well. And then obviously with your bile ducts, they drain out into your small bowel, the duodenum, through something called the major papilla. And again, those of you who've had an ERCP, sometimes we have to make a little cut through the major papilla called a sphincterotomy. So ERCP is obviously an acronym. It's long, it's long-winded, but it's worth going through what it actually means. E means for endoscopic. R is retrograde because we're going backwards up the bile duct as opposed to coming out normally. Cholangio means the biliary tree, and pancreatography means the pancreas. And if we're talking about PSC, then really we should be doing ERC, and we shouldn't be going into the pancreas because we can induce pancreatitis. And we use something called a duodenoscope, which it's quite unique because it's a side viewing scope, and that allows us to sit on face to the major papilla and then access and get in. And there's also something here called a bridge, an elevator. If you're in the US, it allows you to sort of, again, gain access. So these are the UK PSC guidelines, which were published in 2019. I think, was it Martine or Maxine? One of you is an author on these. I can't remember which one of you is, but I think that the key thing here is that if you have PSC, and you're undergoing an ERCP, it should be reviewed, and it says it quite sort of clearly, in an expert multidisciplinary sort of meeting or assessment to justify the endoscopic intervention. And this is a real sort of strong recommendation by the BSG, and it's important because a badly done ERCP in a patient with PSC can have huge implications in terms of complications, etc. So really, people should have thought about it. There should be a true therapeutic target before going on to have the ERCP. So when would you need one, or why would you need an ERCP? Well, these are some of the sort of clinical scenarios which may lead to an ERCP. So usually it may be a rise in your liver blood test, you may be jaundiced, or it may be that you have an infection in the bile duct, cholangitis. And then you need to go on to have imaging, whether it's an MRCP or CT. And only then, after that has sort of explained or given you an indication for the ERCP, do you then go on to have it. So in terms of indications for ERCP in patients with PSC, probably the commonest is if you develop a stricture. Obviously with PSC, strictures go hand in hand, and that's a narrowing in the bile duct, and that may be in the main bile duct, or sort of maybe in the sort of second order ducts on the right or the left side. If it's very far out in the periphery, then we're not going to be able to access that at ERCP. And then sometimes patients can form gallstones. If there's a blockage in the bile duct, then we need to go in and take that out as well. So these are probably the commonest indications for ERCP. There's very few absolutes in life, let alone medicine. But if you are having an ERCP and you have PSC, you have to have antibiotics, because there's a real risk of cholangitis caused by the endoscopist. We're injecting contrast into the bile ducts, which are essentially a sterile sort of system. And sometimes we don't drain all of the contrast very well. So you need to have antibiotics. And again, if people on the call are going to have an ERCP, you should have antibiotics sort of before or during the procedure, on the day, and certainly afterwards as well. And again, this is supported by the EASL guidelines and by the BSG guidelines as well. So that's me done with my little introduction, and I suppose it's over to any questions that people may have.
Brilliant, thank you. That was a great whistle-stop tour of ERCP. So just touching on, you mentioned that it should be, if somebody with PSC needs to have an ERCP, or there's an indication that they may need one, it should be taken to a multidisciplinary team, and decisions should be made with experts. So if somebody has been told that they need to have an ERCP, but they're at a small local hospital and their gastro team wants to do it, is it okay to ask to be referred to a specialist centre or a larger centre?
So ERCP is done in a number of hospitals around the UK, and I suppose it comes down to the individual endoscopist. There's a lot of experienced ERCPists out there who, it depends what the indication is and how confident they feel. I think, in the modern day, it's okay to ask your doctor or sort of team and say, is this something you feel you can do? What is the target here? And if not, then the way we're all set up now, that smaller sort of hospitals will feed into bigger liver centers, and at the bigger liver center, usually there is a more experienced team. So I think, asking your team is reasonable, and if they feel that they can do it, if it's a simple gallstone, then yes, I think that's fine. But you can challenge your team. I don't think there's any problem with that.
I think that's really important as well, as sort of understanding why you're having the procedure done in the first place, and just having that conversation with your team. And then once you get an understanding of why it's being done, you can sort of make a informed decision then about what happens next. So
yeah, and I think one of the other things is ERCP is done in some places under sedation. So as an individual, you need to see what your tolerance may be of having sedation. Will it be enough? At King's, we use general anaesthetic for everyone, and I'll be honest with you, it's probably the best for me, my nurses, but also the patient as well, because they know they'll come into the room, they'll go to sleep, and there'll be no sort of waking up or discomfort. And a lot of the people on this call may have had a gastroscopy, they may have had a colonoscopy, and obviously they may have had an ERCP. And ERCPs can be sometimes quite long, again, depending on what the sort of interventional target is. So, you know, you can ask about sedation as well.
Yeah, very good point.
So some hospitals, when they do RCPs, they don't do a general anaesthetic. Is there a reason for that?
The honest truth is probably, or the brutal truth I would say, is probably money. So to have, you know, a consultant anaesthetist, to have a ODP who supports the anaesthetist, and, you know, an endoscopist, it all costs money. So I think traditionally endoscopy is always done under sedation, but as ERCP has progressed from a sort of diagnostic technique to a therapeutic technique and has got more complex, some centers have said, well, you know, these are tricky cases, you know, may take quite a long time. So, for example, at King's, I think about 15 years ago, way before my time, our medical director and our clinical director for liver said it's all under general anaesthetic. And for us, it takes the thought process out of it. We know everybody will be under general anaesthetic. And, you know, again, if you look at Europe, if you look at the US, a lot of places will give the drug, which is propofol, but may not give a full general anaesthetic. And again, that just comes down to the setup of the unit. Our room for ERCP doesn't really allow for propofol, so all our patients get general anaesthetic.
I'm not sure if anybody would, but if somebody said they didn't want a general anaesthetic, could they just have sedation?
Yeah, they could. You know, a lot of places still do it under sedation. But for example, at King's, there's no, it's either general anaesthetic or you don't have it done at King's. So, but I think most people would prefer general anaesthetic.
Definitely, yeah, I think so.
And just to reverse that question, say you are at a hospital that doesn't give general anaesthetic, or you don't feel you're going to get enough sedation or whatever, can you ask to have your ERCP done somewhere else?
So yeah, absolutely. So a lot of centres now will need to have the provision of general anaesthetic because you know, cases perhaps are becoming more complex, patient choice, previous bad experience. So if your centre does not offer that, then again, you can, you know, ask your team to be referred to a centre that does offer a general anaesthetic. And again, I think that's reasonable because if you've had a bad experience, then you know, why would you be subjected to the same thing again? That seems a bit cruel and unfair.
Yeah, exactly. Now we're getting quite a few questions coming in. Are you happy for us to mix it up a little bit, because some of them are not related to ERCP?
Yeah, of course.
So excellent.
I do other things other than ERCP.
Yeah. Well, you're a consultant at the biggest transplant liver transplant centre in is it in Europe?
I think so. Yeah.
So good, we've got some great questions then. So is there a recommended weight or BMI for transplant?
So there's obviously two extremes. There's a BMI that's too high and there's a BMI that's too low. You know, I'd say a BMI of 40, above that we would start to have concerns, because there comes added risks of ventilation if you're having a transplant, your recovery post-op. So again, we would, as a transplant unit, we would look at sort of weight loss sort of regimens before, sort of during the waiting time as they're waiting for transplant, and then afterwards as well. Going to the other extreme, if it's too low, then the concerns there are that your recovery will be severely impaired. And, you know, BMIs that drop below sort of 17, 16 in an adult, we would not sort of activate on the list, or we would have to suspend, because again, it's just associated with poor outcomes. So if the BMI is dropping a lot, then, you know, NG feeding or supplementary feeding, and, you know, would need to be addressed.
So that a patient with a low BMI, then you would support them with a dietitian
Yes,
to help
absolutely.
them get that BMI up for transplant. Thank you. Okay, another question. Someone who's newly diagnosed with PSC, and she's asking about the routine tests that we get. Are annual colonoscopy and gastroscopy checks enough to check for problems?
So I think if you're newly diagnosed with PSC, and it sounds like this individual has inflammatory bowel disease as well, then yes, a yearly colonoscopy is recommended. From a sort of liver perspective, you know, it depends on the severity of the liver disease, the severity of scarring or fibrosis. So at King's, we would recommend an ultrasound scan to look for any signs of sort of high pressure going into the liver, portal hypertension. A fibrous scan is very useful as well to help stratify patients. The usual blood tests, making sure that there's no evidence of any other liver disease. And then, yes, a yearly scan, ultrasound minimum. What I would say, if you're newly diagnosed, or if anybody who has a diagnosis of PSC, you should ask your team about the availability of clinical trials. There's a number of trials now that are up and running. And again, if your team locally can't support you, then there will be bigger centres that will be able to support you. And having the opportunity of potentially a drug that may help. Obviously, we don't know any of the results yet. Then that's better than having absolutely nothing at all.
And then one of the benefits of going on a clinical trial as well is that you tend to get more imaging, so you might get MRI scans, and things that you wouldn't necessarily otherwise get.
Yeah, I mean, I always think of the clinical trial as a big hug. Somebody's there just holding you more, and they're always there, and they're there more so than your team would be normally. So if you like hugs, yeah.
Yeah, I like that analogy.
We all like a big hug every now and again, don't we? Okay, next question. Thanks for the informative video. So in people with low albumin and rising bilirubin, do we find a higher protein diet successful in reversing this in the body?
So whether you apply that to PSC or anybody with chronic liver disease, I think if your albumin is falling and your bilirubin is rising, then it suggests the liver is really showing signs of strain. Now, this individual, if they've not been seen by a hepatologist or certainly somebody who has an interest in hepatology, needs to be seen because they may well need to be assessed for liver transplantation. They may need a liver transplant. But those two things, when the albumin falls and the bilirubin rises, they're usually when you should be concerned. Diet alone will not reverse that, and it may just be reflective of a liver that's just really starting to struggle.
Thank you. Thank you. The questions are coming in now quite fast. So, good evening. I have PSC and a consultant advised an urgent colonoscopy as the fecal results were extremely high after a bout of cholangitis. This person says they live under an island and they asked for a second opinion more than a year ago. Do you think this is acceptable?
What, waiting for a year?
That's
no,
a long time, isn't it?
No. Obviously different places work differently, but I think, any sort of second opinion should be sort of referred, and you should have an answer back within sort of 6 to 8 weeks, whether it's a telephone call to say, yes, we've received the referral and we're reviewing all of your scans and your history, or, you get an invite up, but a year is clearly too long.
Yeah, and even with COVID as well, the least I think centres can do is communicate.
Yeah,
and just keep that person in the loop.
Yes, I think it's interesting what you say about COVID. Obviously, at the moment, we're not hugging people. I should say that. Social distance, please. But it's interesting. COVID slightly has changed the way we all work, and I think in a positive way, because before COVID came along, there was a lot of red tape over telephone consultations or video consultations, and now all of a sudden that's been removed. People have actually thought these are good ideas, and certainly what we've been doing at King's is, although let's say from March to June we weren't seeing many people face to face, you can still pick up the phone, you can still ring up, find out how people are. And I personally have kept my clinic going because I was scared of the backlog. And if you switch your clinic off for 3 months, the backlog will be over sort of 100 patients or so. So people can still pick up the phone, you can get a history, you can invite people up for tests. You may not get to see them face to face, but you can start pulling investigations. So that shouldn't stop COVID or no COVID.
So would you say it's a good time to maybe chase that up? And
oh, definitely.
Yeah.
I think a year, I'm sorry, that's just not good enough.
Yeah.
No,
Yeah.
definitely chase that up.
And they also made a comment about what we were talking about earlier about general anaesthetic during ERCPs, and they had sedation to remove stones from the common bile duct, and it wasn't general anaesthetic, and she said it was traumatic, and she had sepsis afterwards, and that goes back to your point you made in the slide, doesn't it, about the antibiotics. Does that always stop complications after ERCP?
No. So, I mean, the common complications with an ERCP, so cholangitis or infection is definitely one of them. And the antibiotics, it doesn't negate it completely, but it helps reduce the risk. And like I said, very few absolutes in medicine, but this is one of them. Anybody with PSC having an ERCP needs antibiotics sort of before or during and certainly after. Other sort of complications include perforation, so making sort of a tear or a hole as you're going down the gullet or the stomach. That's very rare. But at the time of ERCP, when you're in the bile duct, if the bile ducts are very sort of friable, they're very fragile, you can cause a perforation there. Bleeding, anything in the body, there's always a risk of bleeding, but it should be low risk. The main one is pancreatitis. Like I showed you, the pancreas sits very nearby, it shares the same orifice as the bile duct. So pancreatitis is there. One of the things I have to say with ERCP, if the patient is under sedation and they're not tolerating it very well and they're moving, anything in life where there's a moving target is much harder to do than when somebody's completely still. So, you know, having it under sedation, although there's perhaps no hard data to suggest it's associated with an increased risk of complications, it would probably make, you know, probably common sense if the individual is moving, that, you know, things are less likely to be done sort of thoroughly. So again, it makes a case for propofol or general anaesthetic again.
Thank you. And does this risk of complications after an ERCP sort of reset every time you have one? So say you did get pancreatitis or ERCP1, if you had one a year later, are you more likely to get the complication, or is it the same?
I mean, the data sort of, when you look at ERCP as a whole, if you've had pancreatitis once, there is an increased risk of getting it again. You know, ERCP and PSC can be very tricky. I didn't mention this bit, but the major papilla, the orifice we try and sort of enter with our sort of wires and things, they tend to be a bit smaller in PSC patients for some reason. So if obviously you've got a smaller orifice to try and get into, it can make it trickier. But you know, it comes back to, I think if it's being done by somebody who's experienced, has an interest, and is going to take their time, then hopefully your complication rate that the patient will suffer is much lower.
Lovely, thank you. Now, on a totally different subject, we have a question about, a good question actually. Many people with PSC and ulcerative colitis have other autoimmune disease illnesses. Is it connected usually, and is there any test for those, or just is it about if the symptoms come up for those illnesses?
So I think, you know, PSC or ulcerative colitis, you know, you would argue that they are autoimmune conditions. So your own body is attacking itself, and in colitis it's in the large bowel, in PSC it's in obviously the liver and the bile ducts. If you have one autoimmune condition, then you're more likely to get a second one or a third one. So we don't screen for other autoimmune conditions if you have PSC, but what I would say is your team should have a very low threshold of thinking about it. So for example, celiac disease, gluten sort of insensitive, sort of, you know, being hypersensitive to gluten or intolerant to gluten, then, you know, you should, if patients describe sort of symptoms of malabsorption, then they're thinking about celiac disease. Relating to the thyroid, if they feel very tired, or, you know, they have sort of, you know, sort of very manic states and very sort of low states with their mood, then again thinking about their thyroid function as well. But I think just if you have one autoimmune condition, then just a very low threshold of thinking about others.
I think that's one of the struggles as well of living with PSC or ulcerative colitis. You don't know, sometimes you're having symptoms and you don't know if it's to do with your PSC, if it's to do with your IBD, or if it's something else completely. And it's really hard to communicate to doctors or, you know, just people in general sometimes and figure out what is going on.
Yeah, I think it can be very hard. Sometimes pain on the right side, if you've got colitis, is it relating to your colitis? Is it relating to your liver? And you almost have to go through things systematically, re-imaging the liver, maybe sort of doing a stool test, a fecal calprotectin to suggest if the colitis is active again, or looking for other potential causes. So, but again, I think it comes down to the team involved. If they have an interest in PSC, then they'll be thinking along those lines or thinking ahead straight away.
Yeah.
But this leads us really nicely onto the next question, and it's a symptom question. And we get asked this so often, and it's about whether a symptom needs to be seen more urgently or not. This person was diagnosed with PSC 3 years ago, but they had symptoms for a few years prior to the diagnosis. But they're currently having a lot of discomfort in their lower right side, particularly around the bottom of the rib cage. Is this something I should get checked out?
So I suppose the answer is yes. If it's there, anything which is persistent needs a review, and either will sort of allay your fears or sort of reassure you. So pain can be quite common in PSC. Sometimes there can be gallstones which are stuck, so some imaging. Very low grade cholangitis could also be a cause. So again, having your blood test and looking for any infection markers. Again, the lower right side, your bowel does come across there, and it's all very compact. So thinking about the colitis, and then again, like I showed you in that slide, your stomach is very nearby as well. Could it be just simple things like an ulcer? So again, if a patient of mine described those symptoms, blood tests in the first instance, looking for any evidence of cholangitis, repeating a scan if they've not had one recently, and then again, just going through things bit by bit and seeing, can we help improve that symptom?
Thank you. And now we've just got 2 comments. So people, earlier we mentioned frequency of routine tests, and one person says they get the ultrasounds every 3 months, but that's normal, isn't it? If there's cirrhosis, then people will get more frequent surveillance.
Yes. So if you have cirrhosis, then you should have an ultrasound scan every 6 months and sort of blood tests with that. And that's mainly looking for development of a cancer, it's called a hepatocellular cancer, HCC, in the liver. If you have very stable PSC, then you should have at minimum sort of a once-a-year liver ultrasound scan. And then depending on the clinician that you see, they may do an MRCP every 12 to 18 months, an MRI scan. But normally, if your disease is more advanced, then you'll have scans far more frequently.
So you would say minimum an ultrasound once a year. That's the bare minimum for PSC.
Minimum, and the reason for that is to look at the gallbladder, because patients with PSC can form polyps in the gallbladder, and they can get bigger with time. So at minimum, it's an ultrasound scan once a year.
Great,
and that's laid down in the UK PSC guidelines as well, so people can definitely ask for that, because there are people that don't get it every year.
Right.
Yeah.
I'm just conscious of the time. We've still got quite a lot of questions. Are we okay to keep going?
Yeah.
Joshi?
Yeah, I'm fine.
Thank you. So somebody here's got stage 1 cirrhosis, and they've got Crohn's disease, and Humira has been suggested for them. Is that harmful to their liver?
So the argument will always be in patients with PSC that you need very good control of your colitis. I think data from big studies across the world have shown that if your colitis is not well controlled, then that usually has a negative impact on the liver. And at a simple way, the way to look at it is all of your blood from your bowel eventually goes back to your liver. So if all those inflamed cells are going from your bowel to your liver, those inflamed cells then can potentially cause more damage in the liver. So again, if your liver is, despite having sort of grade 1 cirrhosis or stage 1 cirrhosis, if your team feel that Humira is safe, then yes, that is fine. But as with any drug in a patient with any liver disease, you just need to keep a very close eye on the blood test and the clinical state of that individual.
And this person's got another question as well about taking calcium supplements and iron, as the iron is low in their bloods. And I think this is something that if patients are seen by a gastroenterologist for their IBD, but they're seen by a hepatologist for their liver, sometimes people want to just double check whether the drugs they're being asked to take are okay for the liver. And we wish that doctors would talk to each other about this. Do you at King's, do you communicate with the IBD, or do you treat the IBD as well as the PSC?
So so a lot of hepatologists will have trained as gastroenterologists, and I'm one of those, but I don't do any gastroenterology anymore. I've just sort of moved purely onto liver, and obviously vice versa. There'll be people who just do gastroenterology, but I think you need to have very close sort of working relationships. So we have sort of a virtual MDT where, again, if we have patients with IBD and a liver disease, whether it's PSC or something else, there's good sort of interactions, talking to each other. We're starting this. What do you think about this drug? Things like iron. A lot of patients with inflammatory bowel disease, will have bleeding, so their iron levels may be low. They may, due to the sort of inflammation, not be absorbing iron. So having supplementation in the short term is a good idea. And it's the same with calcium as well. A lot of patients with any chronic liver disease are at risk of osteoporosis. So again, there may be a good reason for calcium supplementation.
Thank you. Another question about pain here. So someone's had pain for 6 months, and it sounds like she's told her doctors, but they're not doing anything. So if someone's concerned about continuing pain, is it okay for them to keep going back to their consultant to say, look, this is...
I think, you could go back and say, the pain is there. You can ask the question, do you think it's cholangitis? Do you think it could be a gallstone that's stuck? Or sort of sometimes you get a lot of debris as well in PSC, very sort of small stones, not quite a big stone. And I think asking for blood tests, is the bare minimum, and then a scan, which will, again, I would never dismiss anyone with pain, because until you've excluded things that can happen to that individual, then I don't think you've made a fair assessment.
Somebody's also commented to say, what is that pain? What is that upper right quadrant pain that we get with PSC? Because somebody has said that their doctor said it couldn't be liver pain because you don't have any nerve endings in your liver. And we get this a lot on our group as well. People they're told, no, it couldn't possibly be your liver that's hurting. So what is that pain that we experience?
So I think it's a really good question. So I'm not sure, when the liver is enlarged, and in PSC, the liver tends, is not usually enlarged. So the liver sits in a capsule, so you can get stretching of that capsule and you can get pain. But in PSC, because the bile ducts are not normal, the drainage of bile will not be normal, stones may get stuck intermittently, we may not be able to give an answer of what is the pain, it is this, but you have to exclude things like stones, stricture, cholangitis, infection, and then you need to think of a way of how you manage that pain, because leaving somebody in pain is never a good sort of way to sort of help someone.
Yeah. So you might not know what it is, but then there may be solutions.
Yeah,
anyway.
And I think you have to go through it systematically. It's not this, it's not stones, there's no evidence of infection. It might be that when you do the MRI scan and there's a stone or there's a new narrowing, maybe you then need to have an ERCP, or you might find a cause, or thinking laterally, look in the stomach, make sure there's no ulcer. These are very simple things, and everywhere can do gastroscopy, everywhere can do MRI scans, everywhere can do blood tests.
Yeah, thank you.
So we all agree, don't we, that the pain is real, and sometimes we can do something about it.
Yeah, definitely.
And there's another question here that comes up a lot, and that's about taking supplements and whether that's okay or not. So they've mentioned two in particular, turmeric and vitamin D, but on our forums we get asked about all sorts and whether that's okay to take or not. So what's your position?
Vitamin D, patients with chronic liver disease are at risk of vitamin D deficiency. I think in the United Kingdom, due to our lovely weather, we're at risk of vitamin D deficiency. A lot of us will be vitamin D deficient, we'll just never know. So I think taking a vitamin D supplement seems very reasonable. No problems with that. Turmeric, obviously from alternative medicine, there is some suggestion it has antioxidant therapies or sort of benefits. There's no hard data on it. There's no hard data on it in PSC. My recommendation to my patients is always, if you're taking a supplement, make sure you know what's in it. Tell your team that you're taking it, because if your liver blood tests jump up, then we need to know that it's this potential supplement as opposed to the liver overall deteriorating. And I suppose we just have to watch this space. The other one people talk about is milk thistle. There's data on coffee, for example, can help the liver. That you name it, it's there. But I would say anything you take it within the recommended limits, like vitamin D, or don't sort of pin all your hopes to it. It's unlikely to reverse anything, and just tell your team that you're taking it.
Yeah, and sometimes it can actually be dangerous, can't it?
Yes.
Some of the substances, and definitely we shouldn't be having.
And over the internet, be very wary, because people will sell you anything and everything, and half of the time you never know what's the active ingredient.
Yeah, and it's not regulated. Supplements are not regulated like medicines are, so it's always good to ask, I think, before taking. Now, a lot of people will be wondering this now, because you've talked about your practice and so on, and this person's actually, their daughter lives in Australia, and it's about referrals to King's, or whether they could actually come and see you for an appointment, just a second opinion in the UK, or how, and also how would people refer to King's if they want to have their care with you?
So you need unfortunately you can't self-refer, so your GP or your current team, somebody needs to send a referral. On the King's website, King's College Hospital, you'll find sort of, if you type in liver, it'll go to the liver department, and there's a generic email address, and that's the way. And it's always important to know, sort of a lot of your medical history. I think a lot of patients now bring their own notes with them, which I always encourage, and I'd rather somebody come really well prepared with all of their information and questions, as opposed to just turning up and sort of waiting for me to lead things. I always let patients lead. You ascertain far more, but that's the best way for any referral to King's is via the website.
Excellent, thank you. And say somebody who is living abroad, where there may not be a specialist, so in Australia, for example, do you ever have situations where you liaise with their liver doctor and they come to you for advice?
Absolutely. I mean, it's a global community now, and with the advent of the internet and now video messaging, video calling, it's so easy to interact, and a quick email. Obviously, time zones pending, maybe some delay, but it's easily done. I think in Australia, centres in Sydney, they've got big transplant programs, and PSC will be an etiology, will be a disease that they treat. There will be expertise there, but if anybody ever is, wanting a second opinion, we'd be happy to provide it at King's. And I just want to point out, it's not just me. I have sort of specialist nurses, there are specialist radiologists, specialist surgeons, and it's all of us together who provide this service. But we all have an interest, and we would never turn anybody away, no matter where they live in the world or country.
That's brilliant. I think it's really good for people to know that as well, because sometimes, especially with a rare disease like PSC, it can feel quite lonely if you're not getting, and especially if you're not getting the care that you want or feel like you should be getting. So it's really good to know that there is other options. Yeah, brilliant.
Excellent. So we got time for one more question. This is about biopsies. So somebody had a biopsy and it seemed okay. They went home, then they got chills and a fever and pain, and ended up in A&E because they got an infection and they got a clot on their portal vein. They're asking if is this kind of something that you would expect to happen after a liver biopsy? Is it one of those things, or were they just unlucky?
I think they were probably unlucky. So liver biopsies in PSC are not routinely done. So, the practice is normally blood tests, some form of imaging, an MRI scan. And if there's still some uncertainty about the diagnosis, then you can move to biopsy. But if you've got an MRI scan which shows the changes of PSC, then you can feel sort of fairly confident with that. But developing what this person sort of describes, their sort of chills, sounds like an infection, and any infection in and around the liver, because of the portal vein, and again on my beautiful diagram I showed you, portal vein runs very nearby, you can get a clot there as a sort of secondary result. But I think this individual is very unlucky.
Yeah. But luckily they got into A&E and got some medical attention for it, so hopefully that person's on the mend now. Yeah. And just finally, a last comment: the lady from the beginning that was waiting a long time for her colonoscopy, it wasn't that wasn't for a second opinion, that was the referral for an urgent colonoscopy. So that's absolutely not acceptable. 1 year.
Definitely not.
No. Okay, that's and all the questions now from the Facebook group. Shall we just finish and talk a little bit about the research at King's?
Yeah, absolutely.
So during COVID, a lot of the clinical trials were suspended temporarily. Can you tell us a little bit about what's going on at King's now with research for PSC?
A lot of clinical trials were suspended due to sort of redeployment of manpower, specialist nurses, trials nurses, clinicians. We all got redeployed. So studies that were up and running, we continued to support patients, but we did not recruit any new patients. However, that's all changed. There are 2 new studies which are starting. So we have the urso deoxycholic acid study, which is up and running. There's the Gilead study, which is now up and running, and we're actively recruiting. And then there's a phase 2B study, Chemomab, which is a 12-week study, which is also up and running as well. So we've just had sort of sign off for that. So we have 3 studies that are running, which are obviously, therapeutic drug interventions versus placebo. And then we're recruiting, as always, for UK PSC. One thing it's worth mentioning, we're doing a sort of a quality of life survey as patients come in. I know this is something PSC supporters work very hard and sort of really sort of driven forward. So we now we have a sort of an inbuilt psychology team at King's in all departments, and what we've done is modified a questionnaire that we'll start using and see again if we can sort of find some data which will add to some of the sort of impact of PSC on patients' life on a day-to-day basis, which prior to this and some of this work you've done, we've had no data on, essentially.
Yeah, no, that's brilliant that you've got psychologists involved. I mean, for people with PSC, if only we could actually see psychologists face to face. Talk about things. It's one step at a time.
Exactly. We'll get some good data, and then we can build it into all of liver, and it should not just be just for PSC.
So important.
And the clinical trials, it is important to say that not everybody's going to be eligible for participation in clinical trials. They're quite strict criteria. We've got some information on our website, not the Chemomab one yet, because we're waiting for us to be allowed to share it.
Okay.
Will you be inviting patients that are eligible from your clinics, or will you wait for them to ask you?
No. It's something we obviously we keep a database of all our patients, and at the moment it's only in patients who do not have cirrhosis. It is limited to that, but obviously if we can show some benefit, then bit by bit the drug companies will then include hopefully patients with cirrhosis, with sort of mild cirrhosis, and then even patients after transplant. We are actively looking for patients. Anybody I see in clinic, anybody who's referred, we will always talk about clinical trials, because as it stands, we don't have a good therapeutic drug which helps treat PSC. So, if you have something, it's better than nothing.
And if your doctor doesn't ask you about clinical trials, should you just assume you're not eligible?
No, I think you should always raise it and say, look, I've seen it on, for example, your website. There are these studies. Would I be eligible? And again, the way research works in the UK for the NHS, everybody sits within a research network. So it doesn't matter which hospital you're in, there'll always be somebody within your network who, may be running that trial. But again, if people are willing to sort of travel, then again, bigger centres, King's, Birmingham, the Royal Free, they'd be willing to take patients on. I think it's important to say, sometimes at the start of a trial, it is quite rigorous. You have to attend, maybe 2 to 3 days consecutively, the first month, maybe sort of weekly. But if you're willing to commit, I don't think anybody would ever turn a potential trial candidate away.
Excellent. Well, I think that concludes our session. So thank you so much, Dr. Joshi, for joining us this evening and again giving up your time for PSC patients. We're so grateful. You've answered loads of questions again. So yeah, thank you so much. And thank you everyone for asking such brilliant questions. And we'll see everyone soon.